Okay, good afternoon, good morning, everyone, depending on where you are. This is Steve Sirheinrich. I'm a co-founder at Curvo, and we are really excited. I want to welcome you. We're very excited about this webcast. If you've joined us before, you know that we do these Curvo Quick 30s where we focus on a category and look at it from a sourcing perspective and a surgeon perspective and talk about the category and the strategy and approach to sourcing and contracting within there. So we're very fortunate today to have Dr. Spanyer join us, who is an orthopedic surgeon out of the Cincinnati area. We've gotten to know Dr. Spanyer over the last year or so, and he's got a lot of great insights to share around the total joints project. So before I hand it off to Andy and Dr. Spanyer, I do want to point out, we'd love to have your questions on this. So there is a way for you to ask questions. At the bottom of the Zoom box there, you'll see a Q&A button. You can at any time click that and you'll be able to ask a question, or you can go straight to the chat. And that's kind of cool because if you click on that, others in this webcast will be able to see what you're chatting. You may get some conversation back and forth. So I'd encourage you to do either one of those, but please ask your questions. We will spend time on that towards the end, and I know there'll be a lot of questions there. Okay, well, we'll get started. Andy, I'll hand it over to you.
All right, thanks so much, Steve. And Dr. Spanyer, welcome. Thanks for joining us today. We're really honored to have you. I had the privilege, as Steve mentioned, of getting to work with Dr. Spanyer and get to know him through a total joint project at St. Elizabeth. And our team was just really impressed with his leadership and the way that he took the mantle. And also want to publicly thank you, too, for some of the ways that you had suggestions for looking at the data that influenced the way that we made improvements to our modules and some of our analytics. So again, welcome. And, I'm going to leave it to the audience as to which of the guys on the screen is better looking, the guy on the the gray supply chain flunky or the orthopedic surgeon. So we'll try not to make those determinations today, but
maybe we'll cast a vote. Who knows?
We could use the polling feature.
Yeah, there are polling
Oh
options.
boy,
We never used it before.
It's probably not a good way to start the polling feature.
What are you trying to say, Dr. Spanyer?
I don't want to lose. That would be devastating to me.
All right. Well, just allow me to make this introduction for the audience, a little bit about your background. Degree in biomedical engineering from University of Cincinnati, MD, University of Cincinnati, residency in orthopedic surgery at University of Louisville, and then fellowship trained at Mass General and Harvard. Also published author and, a mission-focused, good-hearted gentleman with doing some medical mission work in Honduras, Ecuador, and Haiti, and also named a top doctor by Cincinnati Magazine in 2018. So pretty cool. Congrats on all your success there.
Thank you.
Yep. And as a quick refresher for our audience, as Steve mentioned, our format for these Curvo Quick 30s is we really like to look in detail at an implant and physician preference item category and get a sourcing perspective from people who really know their stuff and talk about what they see that's going on in the category and the work that they're doing with surgeons. So we did part one of this for arthroplasty products with Bruce Cavanaugh from New Hanover Regional Medical Center. We did that a few weeks ago, and now this is a follow-up, part two with Dr. Spanyer. What some takeaways were from Bruce's analysis were really these key drivers of success in their organization. It all started with trust and transparency between hospital and surgeons. Second tenet was really a reliable service line team. So they had the service line team structure that provided the venues through which they could share data, they could collaborate. Then they also had really good service line liaisons who were close to surgeons and close to supply chain and could be good, reliable intermediaries and team members and partners. And then they had a really strong foundation of data and analytics. So I thought I would just provide that as a refresher for our audience. I'll ask anybody that's interested, if you'd like to go back and listen to that webinar, download those slides. It had a lot of really good results from that. And Dr. Spanyer was kind enough to complete a profile as well. We've got the answers to his questions that he did for that. As part of those slides you can download as well. So Dr. Spanyer, enough of my rambling. Everybody's anxious to hear from you. So we can take this, multiple directions. The main thing is for us to really get to hear your story as an interested, cost-conscious surgeon who kind of became a champion and a leader among your medical practice and in your hospital organization and doing some of this work. As you look at Bruce Kavanaugh's characterization of success drivers, trust and transparency, good service line leadership in the hospital, and strong data and analytics, what are your thoughts on those success drivers? Agree, disagree, any omissions?
No, thanks, Andy. I appreciate the opportunity. There is no question that if you want to be successful in this area, both from the hospital side and from the physician side, whether you're employed or not employed, whether you are, private practice, et cetera, you have to have those key elements. You have to have trust. You have to have transparency. I think it starts there. Essentially, just like anything, if you're trying to win a basketball game and you've got 5 players who aren't playing on a team, you really have to align the team members first. And so trying to get that alignment and building it through trust, transparency, and collaboration, it has to be the way to go. You will never get anywhere in this process without it. I think the bigger picture, and I'll take a step back for just a minute. The bigger picture is that healthcare costs in America continue to increase. We are, healthcare debt. If you look at debt in America, it continues to spiral out of control. I think we're over $19 trillion now, and healthcare is a major part of this. Closing in on 20% of the gross domestic product is what we spend on our health. That's $1 in $5 that are earned in the United States that goes towards healthcare, almost. And so that number is just astounding. And part of the reason that happens is because certain products and certain procedures and such remain unchecked. If you look at joint replacement, this is an easy area to sort of target, because procedures, particularly for hip and knee replacements and coming online with that shoulder replacements, the numbers continue to increase. There's no question that the number of hip and knee replacements in the United States will continue to increase. The predictions from 2010 to 2030 have something like a 600-fold increase. So 600%, 6 times more by 2030 compared to 2010 in terms of knee and hip replacements. If you look at knee and hip replacements, there's more than 1 million procedures that are done in the United States at this point every year. And there's millions of Americans that are walking around with functioning hip and knee replacements. And so at some point when the supply increases, or I suppose when the demand increases and the supply increases as a result, it's natural that there will be economies of scales. It's only natural that if you're making many more of these devices, you can make them for less expensive. And so, at some point, it's also a little absurd to think that the price that you pay for an implant in 1990 is going to be the same price that you pay for it in 2018. And so that's a lot of where this comes from, and sort of looking at it and saying, okay, how do we drive to more effective pricing, and more efficient pricing, more effective delivery, and anyway, that's what this is all about. It starts with trust and transparency. Yeah.
Well, what are some ways that trust and transparency between an administration and a hospital and a medical staff is built? What really are the seeds of it? What are some of the most important curiosities that you have as a surgeon that a hospital can really answer for you that helps to start to build that trust and transparency? I know Bruce was talking about, we share device costs, we share reimbursement, we share margins, et cetera. From your perspective, what builds that?
Yeah, I agree. I think Bruce's point is well taken, which is, to be open with that. Honestly, in some ways there can be distrust between team members, right? Your first team member, of course, is going to be the hospital system. The second team member, the physician group, and whether they're employed or not, there may be some difference between those two groups in terms of what they accept and how inherently trustworthy they may be. But I think looking at that, when your communication lines are open, if you're having regular meetings with your surgeons, if you are communicating about other things, which you should be anyway from a hospital perspective, about service line needs and such, that will always build trust. Now, beyond that, how do you align incentives? And I think that's what this really gets to. Certainly, there's a lot of opportunities that are, well documented, and certainly, in the legal arenas now that have to do with gain sharing and looking at aligning incentives so that if monies are saved, then a certain percentage of that goes back to the physician group.
Mm-hmm.
And I think that's a great way if there's concern about the alignment, or if there's concern about all players being on the same team. I think that's a great way to get it kicked off and get it started. It sort of piques the interest of both groups.
Yeah, definitely. So you'd characterize the financial incentive as a helpful link, and acknowledging that as a potential motivator, but not even really the strongest driver. Is that accurate?
I would agree. Yeah, well, here's the thing. If it is the strongest driver, if that's the only reason you're doing it, then you sort of miss the boat.
Right.
In many ways, you should, I personally take pride in the work that I do. I think most orthopedic surgeons do. I'd like to do the best job I can, consistently provide the best outcomes at the most economical and most reasonable prices. The fact is that not every patient is the same. Not every patient needs a pink Cadillac hip replacement,
right.
and sometimes a Toyota will do, or whatever, or a Chevy, or whatever brand you'd like to choose. And so I think that opens up an opportunity for, what we call demand matching, meaning that the 85-year-old who's getting her hip replaced is different than the 35-year-old who's getting his hip replaced or knee replaced, et cetera. And so that's helpful, because the technology then is different. There may be cost association that's different with that technology as well. I think it goes back to being, in some ways, proud to be an American and taking care of our country, and looking at being responsible with limited resources in a country that has the best and the brightest. And so I think that has to be the driver. I think the driver of excellence has to be your goal and your interest. And I think secondarily, if there's monetary gains, I think that certainly brings teams together. If there's open communication, that brings teams together.
Yeah, no, I think it's a really important lesson for all of us, and folks in the audience in particular, that they probably have medical staff members like you in their organizations who have had this growing passion for cost improvement, for cost conscientiousness. I think, and I don't want to put words in your mouth, but I think maybe at times in various organizations where you've been in, it's been difficult for you to get information about what devices cost, and it's really mattered.
No question. Yes, I totally agree. And isn't it interesting that the same organization that maybe holds on to some of that data doesn't really realize the value of sharing it. It's almost like a secret, which is understandable, but at the same time, there's value in knowing that, not just for financial purposes, but for a deeper purpose, which is trying to get sort of the best value, driving at what is the value of what we're really doing here.
Right.
And I think value is really that ratio. It's been well defined as essentially the outcome per unit cost. In other words, what kind of outcomes do you get per dollar? And so if you don't know the cost and all you know is the outcome, then you really can't understand value.
Yeah, no, I'm with you, and I think it's just such a great story. Like the data, you were this motivated, cost conscientious surgeon who was even frustrated at not being able to get information at various places where you practice. Some of that information begins to be shared. You're kind of unlocked as a champion, as a leader. You bring colleagues around who may not have cared as much about cost or about the initiative, and all of a sudden you've got a budding, great relationship going on between the hospital and the medical staff. I just think it's so cool. I mean, I commend your work, and we want the takeaways for our group here of what they can do to help identify and engage the medical staff members they've got like you into these kind of champion and leadership positions.
Sure. Yeah, and I think you're kind of alluding to our story, and I think I'll share it a little bit in more detail there, Andy. But you know, essentially, we're in a hospital system, much like many of the others across the country, that has a private hospital system and a private private orthopedic group. We work closely with the hospital system, but we don't work for the hospital system, and so you can see immediately how incentives are not necessarily aligned there. And we have surgeons who, like most places, surgeons who have been very comfortable with their implant selection or with their cost, the prices that they've been getting for implants for, in some cases, decades, in some cases, 10 years, in some cases, 5 years, and so forth. And as a result of that separation between the person who's doing the purchasing, that is the surgeon's choosing the implant, and the person paying the bill, that is the hospital, that results in a separation that can be easily conquered by implant companies. And so they keep the prices the same because the surgeon's already comfortable with that implant system, and so you're essentially paying what you paid 10 years ago, which is not appropriate. Those prices should be coming down. Everything changes, you know, including implant pricing. Again, this goes back to economies of scale. And so what we did really was to open that communication. And when the communication was open, of course, that was started by the hospital side, which is appropriate. They're the ones paying the bill. That immediately resulted in some concern and some animosity from the surgeon side. And because it was like, well, why do you want to change what we use? We like what we use. And so, you know, the first thing to do was to align incentives by saying, okay, well, if we find opportunities for improvement in cost and improvement in our supply chain, then that can be shared, or a percentage of it can be shared. And then the second absolutely critical piece was to share the data openly. And that data, we could not have possibly understood what that was without the assistance of Curvo. The data that came from Curvo was detailed line-by-line item data that really allowed us to understand what were the costs, the true cost of the implants that we were using, and how did that compare to other companies, and where did the sort of different companies' quotes come in. I think the most powerful component of Curvo's data was to really allow us to understand national benchmarkings as well as regional benchmarkings. It helped us see that, hey, wait a minute, we are, you know, performing very poorly. We're using a very large number of joint replacements. Our system is very busy in terms of the total volume, and yet we're paying 90th percentile pricing for the majority of these implants. So although we have a large volume, we're really getting a poor deal on that volume. And so that opened the door for a tremendous amount of communication. These things take time, but you know, sort of multiple meetings, multiple iterations and discussions about number one, why was that happening, and number two, what could really be done about it. And so it was a wonderful opportunity for us then to say, okay, our interest and our goal is to improve value in healthcare. How do we do that responsibly, still get you know, appropriate and what we thought were effective prices on implants, and how do we drive that? And so that's sort of the rest of the story. I think we've been very successful with that, and I think it's really gone well from our side.
Yeah, well, you know, we were honored to be a part of it, and it was great work and really cool to watch you kind of take the reins with that and work with the folks at St. E. It's just, you know, really a neat project. And yeah, great. So how would you think, you know, we see this sometimes where you've got other surgeons, part of your practice, that maybe they don't have this passion for cost or this, you know, curiosity or intense curiosity about costs that you may have. You know, sometimes we see things matter to them like charge to the patient. You know, they care quite a bit about whether or not we could reduce the cost to the patient or what the patient's bill is going to be. What are some ways that maybe helped engage those partners who weren't as motivated by cost as maybe you have been?
Yeah, so that's a great question. I think, and what I think honestly, what you're getting at is somewhat of a paradigm shift, right? Across the country, across the world in many ways, but especially across our country, there has been a shift of sort of fee for service to fee for value, or paying for value outcome. And this goes directly in line with that. And what you're really saying is, well, how do you get a surgeon who's in his 50s or 60s, who's thinking about retiring in 5 years, to care about any of these things?
Right.
And the answer is that it's not sustainable how we are. In other words, how do you get a surgeon to care about sort of irresponsible spending and irresponsible medicine? And I think the answer is to do just exactly that, to point out the fact that, as they say, times they are a changing, meaning that there is this paradigm shift towards value-based care. There's a tremendous amount of now bundled payments that are important to consider, and implant costs and supply chain costs fall directly in line with that. And to look the other way is to not look and see the not look and see the storm coming in some ways. I mean, you can't miss it. And so I think that has to be central to, and it generally is central to most physicians. They care about their patients. They care about their system. They care about their financial situation nationally and so forth. And I think pointing that out is an important driver for this.
Yeah, oh, that was awesome. I think you ought to go on the speaking circuit. The idea, no, seriously, that just to kind of characterize it, I mean, irresponsible spending is irresponsible medicine. I mean, that's pretty cool. That's profound. So I know we're going to have a lot of interested folks in the audience that are going to have questions for you. Are we good to open that up now for the last few minutes of our webcast?
Oh, certainly. Absolutely.
Yeah. All right. Well, Steve, I'm going to hand back to you to start to take some audience questions. Folks that are listening, it's a great opportunity to pick the brain of a passionate, cost-conscientious orthopedic surgeon who's doing good work in this space and helping a hospital reduce costs through some pretty neat and innovative ways. So, Steve?
Okay, thanks. So right now we got one question in the queue, and I'm sure there are more, like Andy said. So just a reminder, the Q&A button or the chat. Please enter your questions there. And so this one, Dr. Spanyer, comes from Patrick, and I think it's similar. It kind of hits on what you just talked about. Patrick says, "What is the approach to senior leadership / administration and surgeons when there is a lengthy tenure? While tenure is great for organization stability and knowledge, there is a downside, and that downside would be breaking new ground."
Yeah, that's such a great question. It's such a good point. Gets back to what we were talking about earlier, Patrick. I think that this concept of value-based care is relatively new. It's in the last 5 to 10 years or so, especially has taken off in the last 5 years, and especially centered around adult reconstruction, hip and knee replacement. The reason is because it's increasingly in demand, it's expensive, and there's opportunities to improve both outcomes as well as decrease cost and thereby increase value. To get specifically to your question, sometimes the leadership can come from behind. What I mean is, for example, I'm one of the younger partners in our group, but I think this forward thinking and being vocal about it can be a key driver for success. I think recognizing as well that this is the trend, this is where things are going, especially from a hospital perspective. If hospital administration simply points out the fact that there's many more bundled payment programs, there's many more alternative payment programs that are available. Medicare is a great example that something like 30% of all of their procedures now go through alternative payments. They expect in the next 5 years something like 75% of all their procedures will. So they're expecting more than double in the next few years. And these alternative payment models, they're not going away. The private insurance companies do the same. And so recognizing that this is the future and that this is where we're headed, and recognizing, in spite of a tenured physician, that there may be a tremendous opportunity, or tenured administration, there may be tremendous opportunity to look at it in new light, is invaluable. I'm not an employed member of Curvo, but what I will say is that without that data and without the transparency of seeing the details and some national benchmarks, we never would have been able to do any of these things. And so it's just extremely valuable to have that as a tool to start some of those conversations with the leadership.
Yeah, well, cool. Appreciate the kind words. Yep.
Yeah.
Got some other questions here.
We do, yeah. So they're coming in. So this comes from Jim, and he asks, please describe how Gainsharing was implemented. I know that's on a lot of people's mind. So
yes,
there's some light on that.
Great question, Jim. So of course it's a legal document. There are many rules about this. The OIG has some rules about what you can do in terms of Gainsharing and such. There was legal counsel involved, et cetera. But essentially there's a document that's drafted and is reviewed from legal counsel that allows for Gainsharing, and the two groups essentially agree on that. In our case, the minority of that really came to our group. The overwhelming majority went to the hospital system. But it was still beneficial to us, and of course we still have interest in this area. It's hard to see your hospital system really being taken advantage of, simply because there's been lack of cooperation between groups. So I think we were very helpful in that regard.
Mm-hmm.
In fact, we continue to be helpful in that regard. It's kind of interesting. There's always more that comes along.
Yeah, that's good.
Great.
Okay, this one comes from, I believe, from Aaron. And so, learning from hips and knees that wrapped up before. Okay, so this is a specific question about his hospital. So they're learning from their hips and knees initiative that wrapped up before he arrived. Revision components seem to be suppliers' back-end way of gaining some margins back after agreeing to capitated constructs. And so I think this is just a general, what are your thoughts there?
Yeah, Jamie, that's really a good point there. It's absolutely true. Revisions are such, depending on your system and depending on what kind of volume you do of revisions. Some systems do a tremendous volume. We do quite a reasonable share of revisions in our center, but for centers that are doing less of those, you can really get hurt on the revision side. You can really look at it and say, geez, boy, we saved all this over here, but we have these 10 revisions a year and we just got crushed there. So you're absolutely right. What we did in the way, because there's such one-off components, in other words, sometimes you change just one part or one stem or one liner, et cetera, what we did is essentially negotiated a percentage off list price for revision components, because it would be too difficult to go through and predict exactly which revision components you need. There's really no way to know that until that patient shows up on your front door and has a failed knee replacement. So essentially that was our strategy. As we said, okay, we'll negotiate a certain percentage off. That was helpful to us.
Yeah, and what Aaron's also asking about is the complicated primaries, to where it's actually, like a universal base plate or something like that. That's technically a revision component, and device companies are using that as a way to increase the cost of the case by using a revision component on a primary. What are your thoughts on that?
It's such an important thing to do. And it's an absolutely, you can understand, it's a reasonable business strategy. That's why it's done to begin with. But essentially what I would suggest and what I would say is that we came to the conclusion that rather than paying for a certain price for individual components, we would create a construct. For example, we created several, companies will give you information, and they'll give you line item pricing and discounts on their implants, and they'll give you a list that's 300 pages long, and you won't be able to read it or get through it or anything. And so it's just outrageous. You get lost in the data. They hope you do. And so instead of that, what I would highly recommend is that you go to a construct price. In other words, you say, look, we don't care what base plate we use. We don't care what femur we use, what implant, what polyethylene liner we use. When we do a total knee replacement, we are willing to pay X for that total knee replacement. When we do a total hip, we're willing to pay X. And we broke them down basically, I think most groups probably would do the same, broke them down into, is it a cemented hip or a cemented or a cementless hip? Is it a partial hip replacement or a total hip replacement? Is it a cemented knee or a press fit knee replacement, and so forth? Is it a partial knee or a total knee? And so that really gave us the benchmarks and helped us to give a target to the companies. What they did internally with the data, up to them. They want to charge this much for the base plate and that much less for the femoral component, whatever. That's their business. What we're interested in is we did a total knee replacement, and we're willing to pay X for whatever parts we use.
Yep.
And companies understandably say, well, the concern is that you would use the best on everybody. And although that's a possibility, and that's true, generally speaking, you don't necessarily need to use the most expensive polyethylene liner on a patient who's 85. You can use a standard polyethylene liner. You don't necessarily need to use a ceramic femoral head on a 90-year-old, but you can, or a total hip on a 90-year-old. You can use a partial hip because that's what's appropriate for their age.
Mm-hmm.
So there are some, a lot of the guidance really goes around that.
Yep. No, it's great. And we're even seeing in some instances capitation on the DRG level, which is a little odd because you typically see a higher price for a hip than a knee, but we are seeing in some instances, if it's DRG 470 and it's a major joint replacement, it's one price regardless. So great questions and great strategy there too. I also like this other one. I'm very curious. This is from Matt. This is there a matrix or method for choosing the appropriate implant for patients? So this is kind of is there a demand matching clinical algorithm out there that helps you kind of right size the implant? That's a great segue from your last statement.
Yeah, that's a really good question, Matt. You really have to leave this up to the surgeon discretion. Forgive me if you are a surgeon, I don't know the answer to that, but for some patients, depending on, it's not as simple as a matrix. Not all 80-year-olds are created equal. There are some that are out there walking 4 miles a day, and there are some that live in a nursing facility and sit in a wheelchair all day. And I think the treatment for those 80-year-olds is quite different between those two patients. Mm-hmm. And so I think you really have to leave that one up to the surgeon. I would simply suggest that there is a difference between those patients, and that the treatment should match them. It should match their need.
Yep. No, that's a great point and a great opportunity to help control costs. We have one question here is about the size of our benchmark group. We have about 15 billion in national purchasing data that populates that. We also purchased Orthopedic Network News, if you're familiar with that publication in the audience, in March. And so, between our two companies, we're really pleased with what we're able to tee up there.
Just say it one more time, Andy, because those numbers are astounding and they're very helpful. Say it one more time. What's the size? How big is it?
It's about $15 billion worth of annual expenditures. It's in our benchmarking database. Yeah.
So essentially what you're saying is that the data, with that much data, is very reliable, and you can accurately say, within some degree of error, pretty small degree of error, what the range is on cost and what the range is on implants, and you can see with that information where you stack up compared to others. Extremely helpful. I don't know how you could get through this process without having some of that information, really all of that information. In fact, as you alluded to earlier, you really have to look at it different ways. I appreciated the flexibility you had when we sat down at a few of the meetings and said, look, we need to slice this data a different way. I need to understand this. And so I'd give you a day, and then I'd have another set of data that would come back. So it's very helpful.
Well, it was helpful for us too. I mean, it was really great, and we appreciated the way you helped shape that. So no, we love this work. It's why we started our company, was to help get those cost and quality wins that come from good strategic supply chain management, and work hand in glove with good leadership at a hospital and good leaders in a medical staff like you. That's what gets us up in the morning. So
sure, happy to help. I think it's a great opportunity.
Hey, I got another question for you, Dr. Spanyer. When have you seen that it is? Is there a technology, and we're talking total joints here, where you do feel an upcharge or premium, I guess, is justified, and how do you recommend supply chain and work with surgeons around identifying that?
That's an excellent point, because like most companies who want to protect their assets, they say, well, yeah, sure, we can do this for total knee. However, if you want to use this new implant or this new stem or this new polyethylene surface, or fill in the blank, there has to be an upcharge for it. And so essentially this comes down to the surgeon, right? The surgeon has to decide, and the hospital needs to help them, whether or not you're going to allow for certain carve-outs for certain technologies. We were pretty quick to say that most technologies would be together, all polyethylene, all plastic parts. We said, look, we know that certain companies feel like they have proprietary this or that, but we're asking all the companies to do the same. And I think you would be surprised that most companies have a tremendous amount of flexibility, even when they say they don't, in terms of pricing and what they can offer in order to keep business. And so I think being clear about constructs and then deciding if there's going to be certain carve-outs, you really have to sort of be careful there. I would just caution you that you can quickly get well over your capitated rate and erase a lot of the work that you've done by allowing carve-outs.
Okay, that's great. Well, I think that's the end of the questions. No more questions are in the queue, and so really appreciate you doing this, Dr. Spanyer, and there was some great questions. I think some really good takeaways. A couple things, Andy, if you'd advanced the slides. For anybody on this call, if you'd like to see your own data in our total joints module, we'll do that at no cost for you, give you an analysis, make some suggestions. This is the same thing that Dr. Spanyer has talked about when he saw the data. So kind of a shameless plug there. That's what we do. And if you are interested, you can contact me, steve@curvolabs.com. And then I do want to share with you all, we've got more upcoming presentations. So if you're going to ARM, August 14th at 2:30 Central Time, Andy will be live doing a learning lab with Pam Dieter, who is the VP of Finance from St. Elizabeth. And it's going to be a great discussion about her experience. She worked with Dr. Spanyer to achieve the outcome, and it'll be her perspective on this, how she looked at her team, how she helped learn what she learned about connecting with the surgeons. It's going to be really good. And then August 23rd, we'll do another quick 30, and it'll be CRM with Stephanie Craddock from Harris Health, who recently did a CRM initiative. Looking at spine, that's TBD in September, and we'll continue from there. If anyone on this call has been recently worked on a sourcing project and you'd like to share, we'd love to interview you for this. You do not need to be a Curvo customer to participate in the Quick 30s. This is for the community, and I would love to hear your thoughts and your ideas on how you went about your sourcing project. So there are replays, though, on our website if you wanted to see. One more slide, Andy. If you want to see the previous ones we've done, endoscopy, sports medicine, interventional radiology, joints part 1 with Bruce Kavanaugh is a great one before this. Feel free, you can go to that URL or just go to our website and look at the top under resources. All right, well, I think that's it. Thank you, Andy. Thank you, Dr. Spanyer. This has been a great discussion. If anybody has more questions, feel free to ask either Andy or me offline. Andy at CurvoLabs, Steve at CurvoLabs, and we'll get back to you right away. Everyone have a wonderful day.
Gentlemen, thanks very much. Bye-bye.
Thank you. Bye-bye.
Bye.